Hello and welcome back to my channel. So today we are going to deal with a new topic, that is healing of extraction wound. This has been asked as a 5 marker in oral pathology and as a 10 marker in oral surgery. So we will be starting with first the healing of extraction wound, how an extracted wound heals, followed by the complications of the extracted wound. So we're going to take a deep dig in the pathogenesis of everything and how it occurs. Right, so starting with healing of extraction wound. First, healing immediately occurs by removal of tooth. So first is you're going to extract the tooth from the tooth socket, right? You're going to extract the tooth from the tooth socket, and then once the extraction is done, the tooth socket is filled with blood. Okay, then after which the intrinsic and extrinsic pathways of clotting cascade are activated. So as soon as the blood fills the clot, the intrinsic and the extrinsic pathways are activated. Then the resultant fibrin meshwork, which contains RBCs. Okay, so there is a formation of meshwork which contains RBCs and your blood vessels. It seals in the PDL. Okay, then seals of the blood vessels in the PDL reduces the size of the extraction wound. Basically, this fibrin network or meshwork that has been formed gets sealed off by your fibrin meshwork. Okay, then after that there is an organization and clot begins within the 24 to 48 hours. So once there is a meshwork, that is your clot, and then the clot starts organizing. That is your vasodilation of the blood vessels near the periodontal ligament starts dilating. Then there is leukocytic immigration followed by fibrin layer. So this meshwork that has been formed is having engorgement of blood vessels, right, within the PDL, and then these blood vessels dilate to give the clot. Your leukocytic migration also occurs and your clot forms then there is a formation of fibrin layer. Now the collapse of the unsupported gingiva into the open fresh extraction wound occurs. So once the extracted wound is open, the gingiva opposing the extraction falls in the extraction wound which is unsupported. Then this is a great aid for maintaining the clot in position. Now coming to the first week, so there are weekly changes which occurs. Basically there are three progressions of 3 weeks. We're going to see what happens in these 3 weeks. So in the first week, the clot forms a temporary scaffold. Okay, so a temporary scaffold is formed. Clot forms a temporary scaffold upon which cells associated with the healing process migrate. Okay, so first clot forms, then there is a temporary scaffold upon which cells associate and healing process is migrated. It is gradually replaced by granulation tissue. That is, all this is again similar to your primary and secondary healing. Your clot is formed, your fibrin layer is formed, the fibrin layer is then accompanied by your granulation tissue. Then there is proliferation of your fibroblasts from the connective tissue cells. Then this fibroblast grows into the clot, around the clot and the entire periphery, forming a scar or a scaffold. Okay, then the epithelium at the wound periphery grows at the surface, okay, forming your epithelial spurts. Then your osteoclasts accumulate at the alveolar bone and set a stage for active crestal resorption. So they resorb the crestal bone that is present, right? Then after that, angiogenesis occurs, proceeds in the remnants of the periodontal ligament. Now in the second week, the blood clot formation continues and gets organized by fibroblasts growing into the clot, fibrinous meshwork, new delicate capillaries penetrate into the center of the clot. Then the remnants of the PDL gradually undergo degeneration and no longer are recognizable. Wall of a bony socket appears lightly frayed, and trabeculae of the osteoid slowly extend into the clot, forming an alveolus. So once there is a formation of your clot, that clot is accompanied by your osteoclasts, which actively resorb the crestal bone. Then your angiogenesis occurs, followed by your fibroblasts, which grow over the clot and form new capillary penetrations. Then the wall of the bony socket is slightly frayed. Then the trabeculae of the osteoid extend into the clot, forming the alveolus. Then the margin, that is your alveolar socket, exhibits prominent osteoclastic resorption. Epithelial cells proliferate over the surface of the wound and is extensive proliferation. In the third week, the clot completely organizes by maturation and granulation tissue. Then calcified bones formed around the entire periphery of the wound or the socket wall. The early bone is formed by osteoclasts derived from pluripotent cells of the original PDL. Then the original cortical bone of the alveolar socket undergoes remodeling. So this is a little too much and complicated to understand. So we just understand that there is a clot formation. Then after the clot formation, there is a formation of a fibrin layer. This fibrin layer further undergoes below this fibrin layer there is a formation of your granulation tissue. This granulation tissue is accompanied by your polymorphs, that is your macrophages and PMNs, after which you have your fibroblasts, which are coming and depositing collagen parallelly. Then once collagen is deposited, there is a formation of scar. While all this is happening, your bone surrounding this socket is getting classed. Osteoclastic activity occurs and it is getting resorbed. Then there is a formation of epithelium over the wound surface. So this is all happening in your second week. Then in your third week, this granulation tissue is matured, followed by the calcified bone of the periphery, followed by the new bone formation at the periphery. Then that is your active bone remodeling that is happening in your fourth week. So in the third week, there is basic maturation of the granulation tissue. After that, there is a crest of the alveolar bone causing osteoclastic resorption. Then in the fourth week, active bone remodeling is seen. Then the bone is filled with alveolar socket continuously for several weeks. Then the radiographic evidence of the new bone is shown. So that's all. That after your fibrin layer, your collagen deposits, your granulation tissue, macrophages, these granulation tissue matures, and this bone that had been resorbed with your osteoclastic activity is now being remodeled and redeposited. That is all happening in your fourth week. Okay, so then eventually there is going to be a formation of scab, then scarring. So that is about your healing of extraction wound, right? Now coming to the complications, this is very important and has been asked a lot of times in the dental papers. So first is your dry socket. So they do not ask only as a dry socket individually. They might ask as alveolitis silica dorsa, localized acute alveolar osteomyelitis, and alveolar osteitis. So remember, ASD, acute alveolar osteomyelitis, and alveolar osteitis. Itis stands for inflammation. So any inflammation or infection in the bone is your dry socket. And your alveolitis is also having itis. So that is how you identify. Now the definition of dry socket. Dry socket is a focal osteomyelitis in which blood clot has disintegrated or lost, exposing the underlying bone. So now, as we were reading the healing of wounds, the healing of extracted wound, that there is a formation of the clot below which all your granulation tissue is occurring, which is maturing and all that. But during this process, if this clot itself wards off, or it displaces or disintegrates, losing its position, so then it is going to expose the underlying bone, and there is going to be a characteristic symptoms, that is your throbbing pain, foul odor, okay, but no suppression, that is there won't be any pus, but there will be throbbing pain and foul odor. Now coming to the epidemiology and risk factors. Frequency, it frequently occurs in 1 to 4% of all extractions. So the occurrence of dry socket is 1 to 4% of all extractions, okay, 1 to 4% of all extractions. Then location, it usually occurs in the mandible more commonly than the maxilla. Coming to the age, it commonly occurs in patients with 40 to 45 years. So this is all your clinical features, okay. Then so the first clinical feature was your frequency. It occurs 1 to 4% of all extractions. It occurs more in mandible than your maxilla. Then age is, it is more common in patients from 40 to 45 years. Gender is more in women. Then habits is more common in tobacco users. So basically, if you start from dry socket, what do you write in dry socket? Dry socket is occurs when there is focal osteomyelitis, and then due to which there is a loss of blood clot, meaning the blood clot disintegrates, exposing the underlying bone. Common symptoms are your throbbing pain and your foul odor, right? Foul odor. Now coming to your epidemiology, is your risk factors are your frequency is, it occurs in 4% of all extractions, more in mandible, and age is it is commonly seen in patients from 40 to 45 years of age. Coming to the gender, more common in women than men. Now the habits, it is more seen in tobacco users, okay, common in tobacco users. Etiology, more frequently associated with traumatic extractions, okay, it is associated with traumatic extractions. So 1 to 4% of all extractions. Mandible is more common than maxilla. Age is patients with 45 years of age. Gender is women. More common in tobacco users. Most frequently associated with traumatic extractions. Most commonly follows removal of an impacted mandibular third molar. Teeth that fractured during extraction rather than removed in toto. Okay, so these are all your predisposing factors. Female is a predisposing factor. Mandible, occurring mandible, okay, that's not a predisposing factor, that's the location. Age could also be a predisposing factor, and your habits such as tobacco users is a predisposing factor. Coming to the etiology, most frequently it could be your traumatic extractions or the tooth fracture during extraction. Systemic factors which include complications such as your Paget's disease or patients undergoing radiotherapy, and it is also common in patients taking oral contraceptives. So estrogen component in oral contraceptive enhances fibrinolytic activity, okay. So the estrogen component in the oral contraceptive enhances the fibrinolytic activity, okay. So your etiology was your traumatic extractions, fractures, and Paget's disease, patients with radiotherapy, and most importantly patients on oral contraceptives, right? Then coming to your pathogenesis. Pathogenesis is the destruction of clot is caused by an increase in fibrinolytic activity via two mechanisms. So there are two mechanisms that are occurring, that is causing your increase in your fibrinolytic activity. First is your plasminogen dependent pathway and plasminogen independent pathway. So your first one, plasminogen dependent pathway, that is trauma to the alveolar bone or local tissue liberates activators. These convert hepatically synthesized plasminogen into plasmin. So first pathogenesis is your plasminogen dependent pathway. Plasminogen dependent pathway. Okay, plasminogen dependent pathway. In this, plasminogen is getting converted into plasmin because they are acting as an activator. Okay, this is plasminogen dependent pathway. Okay, dependent pathway, right? Now the trauma to the alveolar bone or local tissue liberates activators. These convert the hepatically synthesized plasminogen into plasmin and acts on fibrinogen and fibrin causing clot dissolution. Then plasminogen independent, so they are not dependent on plasminogen. They directly produce proteolytic enzymes and local bacteria. Now coming to the clinical features. What are the clinical features? First is your duration. It starts by second or third day post-operative. So after extraction on the second or third day, it gets activated. It starts. Okay. Then pain, it is extremely painful. Pain radiates to the ear and neck. Then associated sign is low-grade fever and ipsilateral lymphadenopathy. Now the socket appearance contains decomposed food debris and food and gives the foul smell and taste. Now prevention. So basic clinical features are that there is throbbing pain in the right side. Wherever the extraction is done, on that side there is pain, and that pain is extremely severe and throbbing, and then which it radiates to the ear and your neck. Then followed by there is foul odor and there is food debris in the extraction socket, okay, which gives a foul smell. Now coming, and there is also a low grade fever and ipsilateral lymphadenopathy. Coming to the prevention, how do you prevent it? Complications in healing of extraction wound sockets can be eliminated by decrease in incidence and degree of severity. So you can decrease the degree of severity by an insertion agent into the tooth socket at the time of extraction. So once extraction is done, you insert an agent in the tooth socket. Okay, that agent, what agent it is, we will read. So first is your antibiotics. You give antibiotics to promote healing, such as sulfathiazole. Then your tetracycline tablets to reduce the incidence of dry sockets. Tetracycline is administered systemically. And antibiotic ointment, that is your mysoferrolosis is given. Okay, mysoferrolosis is given. It is your foreign body reaction occurs where the complication. So what is mysoferrolosis? Is a complication of healing of wound, results in formation of a clear space within the area of healing, presence of altered erythrocytes that appear as solitary clusters of spherules. Management of dry socket: clean the socket, dress the socket. Okay, that clean is by irrigation, and then you give antiseptics with a mild warm antiseptic. Socket is typically filled with obtudent, dressing, zinc oxide eugenol, iodoform gauze. Dressing should be changed every day. Most patients come in symptom free. 1 or 2 dressings. Treatment is antibiotics above, then your Debrassian hydrophilic beads that absorb the toxins and trypsin. So treatment is quite a little complicated. You just have a lot of names to remember. First is you insert an agent into the tooth socket. That agent is usually cotton or something to prevent incidence of infection. Then you give antibiotics, that is a sulfathiazole or your tetracycline tablets. Then you give foreign then you manage the socket, that is you clean, that is you irrigate, and then you dress the socket, and then you give antibiotics, that could be Dibresan or trips. Okay, yeah, so that's pretty much about dry socket and healing of dry extraction. So this is majorly asked, and yeah, that's all. Thank you for listening. And here we complete the chapter healing of wounds. My next chapter is mostly going to be on regressive alterations and salivary glands. So do let me know in the comments below if you're liking the video, or if you want to change my style, if I'll change my style if you do not like it or something. Please let me know in the comments below. Thank you for watching. Bye bye.